From Israel, good morning and good afternoon to all of you. It is my pleasure meeting you all in this webinar dedicated to the collaboration of multi-professional team when caring ECMO patients. The use of ECMO device began about 50 years ago to treat newborns who suffered from severe pulmonary failure. Today, the use of ECMO is accepted to treat all patients who suffered from acute pulmonary and/or heart failure and do not respond to maximal conservative treatment. Furthermore, COVID-19 increased the global use of ECMO to save life while adapting new methods and new protocols. I am honored to introduce to you two Israeli colleagues who are staff members from the different professions who will share with you the collaboration of nurses, physicians, and perfusionists involved with the ECMO care. Golan Shukron is a perfusionist and one of the pioneers of the ECMO service in Israel. Golan opened the ECMO program in Schneider Medical Center, the Children Medical Center in Israel, and he is the Schneider cardiopulmonary operator team, as well as the manager of the cardiopulmonary system operators life support army at Belinson Rabin Medical Center. Alex Furmanov is a registered nurse specializing in intensive care and work as a nursing manager of the surgery division at Hadassah Hebrew University Medical Center. Alex holds a master's degree in nursing and has vast experience in nursing care as a clinician as well as head nurse of the neurosurgery and cardiac surgery intensive care unit. During the COVID-19 outbreak, Alex worked as the head nurse of the COVID-19 intensive care unit at Hadassah Medical Center. Both Golan and Alex are members of the professional national team as a national committee member that was appointed by the head of the medical division at the Israeli Ministry of Health and began its work in September 21. The role of the committee is to establish guidelines and standards for all ECMO units in Israel, including new units that started to work during the COVID outbreak, and it's all based on universal standards. These guidelines were adopted by the Ministry of Health and become the basic guidelines for the operating of the ECMO unit in Israel. So without further ado, I refer the floor to Golan, and then following Golan speak, Alex will continue. Thank you for being here with us. It's a real pleasure having you. Alex, Golan, the stage is yours.
Okay. First of all, I want to thank Odeda and Andrew for inviting me to this webinar about ECMO. I want to talk about ECMO, and we can start now. What is ECMO? ECMO is an extracorporeal membrane oxygenator. ECMO is similar to the heart-lung machine. When patient on ECMO, his blood receives oxygen from the artificial lung, and the circuit of ECMO, oxygen need maintained till the patient heart and lung are recovered. We need a little bit patient when the heart and lung recover. When all medical treatment have failed, we have two types of ECMO. We have VV ECMO for respiratory support, or VA ECMO for cardiac support. ECMO can be used a bridge to recovery, bridge to transplant, or mechanical support, like left ventricular assist device, right ventricular assist device, or biventricular assist device. VA ECMO for a hemodynamic and instabilized situation. When we have a cardiogenic shock, we are going to connect the patient and VA ECMO. Now I want to talk, everybody, I think all the people that you know ECMO, they know this diagram. And I want to explain for all the people that don't know about this diagram, and I want to talk about neck cannulation in neonate. We have jugular vein and we have also carotis. Jugular vein, we insert the cannula to the right atrium. The cannula have a lot of port to drain the blood, the unoxygenated blood, to the venous line. And from the venous line, the blood going with the pump or centrifugal pump to the oxygenator. Oxygenator is the lung, artificial lung. From the oxygenator, when we finish the oxygen, the blood, we take the blood to the warmer. When the blood is oxygen and warming, the blood going to the carotis. From the carotis going to the aorta and from all the body to keep the body in a good situation, in the good blood pressure, in a good hemodynamic support. Then when the patient, when the neonate, the VA ECMO is connected to the patient and we have a good blood pressure, we can decrease all the inotropes, all the vasopressor that we can decrease them a little bit and slowly. VA ECMO for adult, cannulation from femoral vein to the femoral artery. We have a long cannula we insert from the femoral vein by the method to insert the cannula, we call it Seldinger cannulation with a lot of dilatators. And the cannula going to the right atrium with a lot of ports. And all the oxygen blood and venous blood going to the centrifugal pump, and from the centrifugal pump going also to the oxygenator. We oxygen the blood, and the blood, oxygen blood going to the arterial line to the femoral artery, and from the femoral artery to the aorta, and from the aorta to all body. It's like the last slide to keep the body with a good hemodynamic situation. Sorry. VV ECMO, as we know, is for respiratory support. I want to speak a little bit about the veno-veno ECMO for respiratory support. We have femoral vein and we have the jugular vein. We insert the cannula to the jugular vein to the inferior vena cava, not to the right atrium. The cannula will be in the inferior vena cava. We take the blood with the centrifugal pump, the blood flow of the patient, and we inject the blood, the unoxygenated blood, to the oxygenator. In the oxygenator, we do the oxygen of the blood, and now the oxygen blood going to the right atrium. Now we inject the blood in the right atrium to the tricuspid valve. We open the tricuspid valve and the blood going to the right atrium, from the right atrium to the right ventricle, from the right ventricle going to the pulmonary artery, and from the pulmonary artery to the sacral lung, and going to the pulmonary veins, and from the pulmonary veins going to the aorta and to all body. Until now, everybody know? Everybody okay? Now I want to talk about our experience. We have 25 years ECMO experience, Rabin and Schneider Medical Center. Our population was cardiac surgery, patient not weaned from heart-lung machine. This is a group, a very bad group with a very bad result. I talk about 25 years. This was our population, patient not weaned from heart-lung machine. Medical staff was afraid to treat patient on ECMO. Nurse afraid to treat ECMO patient. Perfusionist stood near the patient 24 hours a day. The ECMO technology, it was different from today. If I have a little bit time, I can tell you about the different from us, from from us to today. For example, the centrifugal pump before 20 years, we should to replace the centrifugal pump every 48 hours, every 2 days, because the centrifugal pump damage the blood and damage the blood products. And if we don't replace the centrifugal pump, we can give the patient to bleed. And one of the risks of the ECMO is bleeding. For this reason, before 20 years, we replace the centrifugal pump every 48 hours and the membranes after 3 days when we see a plasma leakage. Today, the system can be even 1 month. Management of ECMO patient need a multidisciplinary teams, nurse, physician, perfusionist, and all others. Each one have different and important point of view. In the management of treatment, contributions of all partners is equal and leads to success of the treatment. I want to talk about us, the perfusionists in Israel. Israel perfusionists are medical biotechnologic or medical practical engineer, qualified and specific universal course related to the patient perfusions. Alex, we talk about this today. Three years of study, then 3 years internship only, then we work independently. Like the other medical profession, we are connected to the academical world. A special team was established for ECMO, or did I talk about this before in the interviews? Physician nurse training in seminar, simulators, and practical on animal models to increase knowledge and confidence in third ECMO patients. Before 3 years, we built a team for nurse from Ministry of Health, senior perfusionists, ICU doctors to treat patients on ECMO. The goal was to build ECMO policy for National ECMO Program under the umbrella of Medical Division of Ministry of Health. This is the key for successful collaboration. This is one word with a lot of meaning. Successful team is intensivist with nurse, with perfusionist, and respiratory therapist. Now I want to talk about collaboration. For example, for collaboration, I want to talk about 7 years girl was admitted with a multi-organ failure, was connected to the VA ECMO, normal run of ECMO, except desaturation after 1 day. Okay. Just wait, I think I have some problem. Desaturated after 1 day, and the doctors called to perfusionists to check the ECMO system and what to do. On checks X-ray, we see lung edema. On echo, we see LV standing and unloading. After discussion between the doctors and the perfusionist, the perfusionist recommend to decompress the LV with a Rushkin procedure. With cardiologists in the cath lab, we insert catheter from the femoral vein to the LA. From the femoral vein, we do a Rashkin to LA and connect the venous line to vent the LV. Then the LV can be loaded. We see it's important for lung and unloading heart. And we see the lung and unloading heart. The patient, the girls, was weaned from ECMO and was placed on the elevator. We put in the left ventricular assist device. After 2 months, patient was weaned and extubated. Successful. So we see this case perfusionist was important consultant. Now I want to talk about COVID. ECMO policy update during COVID. With COVID outbreak, perfusionists, physicians, and nurses involved with ECMO care create guidelines to multidisciplinary teams. Odette talked about this before me, but this is in the slide, and for this reason I tell this. The guidelines was national for all ECMO units and increased cooperation over the country. This is one of the benefits, cooperation from all other units. Two centers did training for ECMO. We opened new course for 3 days. Every 3 days, we open courses. After a few months, we open additional 2 ECMO school and training course also by Zoom. Before the Corona, just 2 schools was in our country, in Sheba and in Belinson. After we open, we don't open, but they open in Hadassah and in Hadassah in Jerusalem, in Rambam, it's the north of Israel. We published a learning booklet for ECMO. As you can see, the course was in small group and in large hall to keep the distance between participants. The participant was from all over the country. As you see here, every 3 days, we open a course for 3 days, the period in the Corona. COVID ICU established in the hospital basement and the underground parking in association with the different ministerial hospitals were supplied with the additional ECMO from the Ministry of Health. Number of ECMO system increased from 35 to 110 in 2 months. It was incredible. This is the state of Israel, from north to the south. We are able to increase the number of ECMO centers from north to the south in Israel in a short period. The conclusion. Training complex patient was difficult with all the protecting costume. It was difficult for us, for the nurses and for the doctors to treat the patient with all the protective costume. The first wave was with a high mortality and many complications. Past knowledge was exchanged with the collaboration with the college, and the mortality decreased. Some patient was on ECMO for a month. As you see, we did operation on ECMO in the basement with the corona. We transfer a COVID patient to the ICU in the basement. As you see here also, a Minister of the Defense organized military medical team to help our group. Every morning, we do a staff meeting, and we can see here the monitoring from outside the control room. This is the staff meeting every morning. And here you can see in the hour course with the simulator, with our guide. And that's all. Thank you for attention from Golan Shukron from Israel.
Thank you, Golan, and let's move to Alex, and then at the end we'll go to the questions and answer. Thank you very much.
What about now?
Okay.
Now it's better.
Okay.
Okay, great.
Yeah.
Thank you.
Yeah, thank you. Sorry for the inconvenience. Okay, so we talk about that worldwide, more than 50,000 patients was treated by ECMO support in a total of 47% in hospital mortality. From the same source of ELSO, as you can see on this graph below, more than 20% of the patient has discharged home or to the rehabilitation units, which, as I said before, in total of 47% of mortality rate. The ECMO, in case of COVID pandemic, gives to patient and to the medical team time to deal with the disease and give to lungs opportunity to recover. What about the literature, the early literature that we saw about the exposure of the ECMO team to virus himself? Due to work of machine ventilator and the spread of the virus in the room of the patient, nursing team that working in the COVID ICUs was protected with personal protective equipment. In case of ECMO, we needed to add additional protective equipment to keep for the infection control and to protect the patients. This will impact on accuracy when monitoring the system of the machine. And nursing staff are under strong psychological pressure, fear of infection, fear of failure. Also guide us during the pandemic with guidelines that they developed about how to choose and treat the patient. So the guidelines said, assure the number of patients that the hospital can treat without compromising standards. If needed, transfer patients between the centers. gather the patient at one unit that specialized in treatment of ECMO patient or sending specialized team to take care of only ECMO patients, and positioning the ECMO device so that parameters can be seen from the outside. Also, ECMO also guidelines talking about bedside decannulation, not transferring the patient to operating room or the cath lab. Infection control, as I said before, additional PPE over the regular one, nurse to patient ratio 1:1. It's not usual in Israel. Mostly in regular ICUs, we're working one nurse for two patients. And in the case of staff shortness, and there is no ECMO nurse, the regular nurse with the perfusionist can take care of the ECMO patient. Or in some cases where the number of the patients is large and the nurses are short, ECMO nurse or perfusionist can supervise on few devices in the row, when the regular ICU nurses can take only the patient, not the machines. I want to present you how we feel working with PPE. On the left side, you can see the pictures of the monitor of ventilator without the PPE, and on the right side, with the PPE. So as you can see, this is not the biggest problem because we still, the numbers are big, and we can, even with the PPE, we can sew them very, not clearly, but good enough. But when we take care of the system of ECMO machines, for example, when we needed to check in on air bubble, on the left side, it's without the visor, without the PPE. On the right side, the same machine with the PPE. As you can see, it's very challenging to find the air bubble in those conditions. If we want to check closely, we have the same problem. You can't see the bubble inside the system, the tubing of the system. So our challenging was that skilled staff are needed, who can work with the PPE. We needed a supplement nurse in the staff in COVID ICU. And of course, if there is a problem during the treatment, it can take a time when the perfusionist will come until he wear all the PPE and can enter to the COVID ICU. So it's talking about technical delays because of the protection. Also, we has no recommendation that patient with BMI more than 40, and a lot of our patient was higher than 40 with overweight of 120 kilo and more. In the summary, the COVID pandemic, it was mass casualties event for us. We have short of nurses and skilled personnel. We needed to wear personal protective equipment, and we had technical difficulties to take care of the patient or the system. Thank you for your attention from Hadassah and Kerem Center in Jerusalem.
Thank you.
Thank you, Alex and Golan. So now we're at the point of the webinar where we can take questions from the audience. And you can send those in by using the Q&A tab, or you can raise your hand and we'll unmute your microphone and you can ask a question directly to either of today's presenters. we haven't had any questions come in from the remote audience yet. Odetta, did you have any questions you wanted to start off with?
Yes, although I'm quite involved with this area right now, there's always something that I was very curious when we started to work with the ECMO to take care of those patients, because I don't know how many of you know, but the cost of treatment of ECMO patient is very high. And it's related to the equipment itself. Every disposable part of it is very expensive. It's related to the technology, and it's related, of course, to the qualification of the team, the training of the team, etc. Additionally to this, we also know from the literature that the chance of survival is not very low, but it's about 50%, much as I remember. So I wonder how we make the decision of giving the patient the treatment of ECMO. Is there, additionally to the clinical decision, also some ethical point that involved? Are there additional to the doctors who take care of the patient, some other people involved that are not from the medical part, like rabbi, some priest, or other people that might be involved with ethical issue? Is this taken into consideration also?
Okay, I'll try to answer for this. I know that in the peak of the pandemic, in the second and third wave in Israel, we treat more than 8 patients in parallel. 6 of them was in the COVID ICU, and 2 more patients was after cardiac surgery, so regular patients. And we needed to divide the team that has ECMO training between 2 units, and it's very hard. In the fourth wave, we tried to recognize which patient will benefit from ECMO treatment, and a little bit delay connecting the patient to ECMO machine. In this way, we can share a space, maybe for less patient, but give more proper treatment, because we gather our experience from previous wave. And in this wave, it was the wave with the highest ratio of patients that needed an ECMO machine. So during this wave, we starting work directly with the Union of ECMO intensivists in Israel, and we start to receive patients from other hospitals that doesn't have ECMO support, like Meir Hospital in Kfar Saba, even from the Northeast Hospital in Israel, from Golan Medical Center. So we shared our place and our experience with other medical centers to give a better treatment for the ECMO patient. And of course, I know that in the centers that doesn't have an ECMO support, they waited for a positive answer from one of the center that have ECMO support when they can arrive and put the patient on ECMO. So it was in the consideration of empty bed in the professional center, when to connect the patient to the ECMO. I know Golan traveled a lot during this wave, right, Golan? To bring the patient to Belinson. Our perfusionist Rav traveled more than few times to bring the patient to Hadassah. But it was very good coordinated between the centers by the ECMO Union in Israel.
I want to talk about transfer ECMO. This was one question about transfer. When we go to transfer a patient, even Corona, but you know, the Corona some days is finished, but we have the regular ECMO patient that we transfer from another hospital to our hospital. We go by team with the ambulance, one doctors, one nurse, and one perfusionist, and the driver.
Of course.
We have a particular ambulance that you have everything in the ambulance, in the electricity, the trolley, everything we have in the ambulance, but we bring our equipment also with the machine, with the ECMO machine. We have also a machine particular for transport. We call it CardioHelp. It's a particular machine for CardioHelp. With this machine, we can do it by helicopter also. In Israel, most of the transfer we do by ambulance, except if the patient is in north of Israel, if he's in Eilat, and the center is Sheba or Belinson or Hadassah, we consider to take by helicopters. This is the answer.
Thank you for that, Golan. Yes, you saw that question come in the Q&A there. We have another question that came in through the Q&A from Sean Smith. And Sean says, first off, thank you all for the wonderful presentation. He is certified in ECMO for neonatal, pediatric, and adult patients. And he's participated and co-chaired sessions at the IPRED conference in the past, which hasn't had its in-person event in the last few years. Sean goes on to say the simulations that take place the last day at IPRED are incredibly helpful, and they are definitely highlighted and incredibly helpful. And he's wondering what are your thoughts on incorporating an optional crash cannulation scenario into the simulation that takes place on the last day at IPRED, or more broadly, what are your thoughts on incorporating ECMO short courses for disaster medicine related conferences?
Wow, Shane, this is a challenge. It sounds
okay. I'm going to try to answer these questions. First of all, if you are working with guidelines, with checklist, and you have a good nurse and a good perfusionist, the run should be okay. But sometimes the cannula can be going out, and it's a problem. Try to don't do it. But I know about the case that the femoral artery, we take it down a little bit, and all the blood was in the room. And to keep the patient on the life, we transfer a blood from the artery to the venous line, and we press the femoral artery. And when you transfer a blood from the venous line from the arterial line to the venous line, you can keep the patient on life with a pumping heart. And in this moment, you call to the surgeon to solve the problem, to exposure, to do where is the bleeding, and to insert the cannula, and we can to run the ECMO. Okay. But if you work again by the book, you keep the cannula and good fixation, it's not going to explore something like this.
I'd just like to add something, not for the clinical side of the medical care, but from the idea of the IPRED. To those of you who are not familiar with IPRED, IPRED is the Israeli Congress of Disaster Preparedness, which is under the umbrella of WADEM. And we plan to have another IPRED conference next January. And yes, I think that the idea that you bring up, Shane, is might be very interesting, and I will refer it to the academic committee of IPRED, and maybe yes, maybe they will consider it. I think that it's wonderful, and yes, Alex and Golan, this is something that might be challenged, and we'll put next to you. So we'll think about it. Thank you for the idea.
Okay. But first of all, again, when you put the cannula, you should protect the venous line and the arterial line very good with the protected, and there is no problem to do it. And the ECMO can be run for weeks. And you know, every day we are coming to the patient to check tip to tip from the venous line to the venous line to the centrifugal pump and the oxygenator, the arterial line, and all the cannula and all the connectors to see if we have any clot in the circuit. Every day we are going to do it, and we take a light to see if we clot in the membranous. Sometimes we should replace the membranous, and we measure the pressure before and after the oxygenator to see if we have a gap of the pressure, and sometimes we should replace all the system. That's all.
Thank you, Golan, for answering that. And Sean added a comment to the question he previously asked and said, thank you so much for considering the ideas of ECMO short course and ECMO included in the simulation for IPRED. We don't have any other questions coming from the remote audience. We have a few more minutes left. Alex or Golan, did you have any kind of parting comments, final thoughts you wanted to say before we conclude?
You can conclude, I think so.
Okay. Well, if we don't have any other questions from the audience, I guess we can go ahead and wrap this up.
I just can add that it's a teamwork. No one can be alone and deal with the patient on the ECMO machine. It's really, as Golan presented, it's a teamwork. Perfusionists, nurses, intensivists, respiratory technicians, physiotherapists, even social worker that need to talk with the family of the patient. Most of the patients, they are sedated, very deeply sedated, and it's an uncertain situation, so they need the support also. So it's really a teamwork, and whereas the team is working well together, in these cases we're succeeding.
The collaboration is the key.
Collaboration. Yeah. This is the key to success in any part of the medical situation.
Especially in ECMO.
Yeah.
I think that's a good point to end on. I want to thank everyone for participating in the remote audience today. As we mentioned at the beginning of the presentation, this is recorded and we'll post it online within the next 24 hours. Thank you to Odetta for organizing this as the chair of the nursing SIG. This is probably the third or fourth webinar that Odetta has organized for WADEM, so I'm very appreciative of her efforts. And of course, thank you to Alex and Golan for taking the time to present and share your expertise. And we really just appreciate you doing that for WADEM and sharing the knowledge that you have.
Thank you. Thank you, Odetta and Andrew.
Thank you, Andrew, for everything. Not only this, but also the hard work that you're doing all the time. It's not obvious, and it's really appreciated. So thank you very much.
Well, with that, very kind words. Thank you, Odetta. I think we'll go ahead and conclude this webinar and keep an eye out for upcoming webinars in the coming weeks and months. And everyone have a good evening or good afternoon or good morning, depending where you're at.
For us, it's good evening.
Yeah.
All right.
Thank you very much. Thank you.
Thank
Okay, I
you.
come back to
Thanks to the
operation.
participants. It's a
Bye-bye.
pleasure to be here.
Bye bye.
Bye-bye.
Bye.